program of PHO chapter of IAP. And before we begin today's meeting, let us take a moment to pause and reflect. We are deeply saddened by the tragic plane crash that has occurred in Gujarat today. Our thoughts and prayers are with the victims, their families, and all those who are affected by this heartbreaking event. But we will continue with this activity, honoring them and trying to learn something new on this day. So over to you, Vinay, to introduce the speakers.
Good evening, all. Thank you all for joining. I'm sure it will be a very enriching session today. So we thought about CML that we have not done it for more than 12 months now. And when we thought about it, first thing that flashed was three people in our mind. Deepak Bansal sir, who has been pioneering work in our country with CML. Then in pediatric CML, Dr. Rajan, Brigadier Rajan Kapoor, who has done excellent work. And with adolescent and adult CML, and we will benefit a lot from his inputs. And Nirmalia, Dr. Nirmalia, who is now one of the representative from India for the International CML Foundation. So I need not introduce any of the esteemed speakers. We have Dr. Gargi, who will open our session. She's been a very close friend of mine, and currently she's a consultant in Adyar Cancer Institute, and very enthusiastic academician and a very good teacher as well. So I open the stage for her to start the session, and we look forward to a very interactive and a learning session. Over to you, Gargi.
Thank you, Vinay sir, for those kind words. Just before we start, the first presentation I ever did in PHO in my MD was with Dr. Vinay as my senior resident and Dr. Bansal as faculty. So it's actually a full circle for me today. So good evening, everybody. Welcome to today's session on chronic myeloid leukemia, which is a disease, which is truly a triumph of modern medicine. And although it's a disease of adults, today we'll be talking about pediatric CML. So before, this year, we didn't really have much numbers from India regarding the incidence of pediatric CML. But early this year, the Chennai Population-Based Childhood Cancer Registry report was released for the year 2022. And the incidence of childhood leukemia, childhood CML less than 19 years was around 5 per million, which is significantly higher than that seen in the US SEER database. But one thing to remember that it's a one-year report, and the further trends will actually tell what the true incidence is. Based on our multi-center study, the INPOC study, we've seen a male predominance in childhood CML and a treatment abandonment or a loss to follow-up rate of around 15%. So we all know the cytogenetic pathogenesis of chronic myeloid leukemia. It's a balanced reciprocal translocation between 9 and 22, forming the Philadelphia chromosome, which is actually the 22nd chromosome. This occurs in about 90% of patients, though in pediatrics, I think the number is much higher. Rest 10%, I think, is our variant, cytogenetic variants, which we don't commonly see, and cryptic translocation, which are rare overall in both adult and pediatric CMLs. Apart from these, we have certain additional chromosomal translocations, which are seen commonly in the accelerated and blast phase, and various pathways are involved, like the trisomy 8, trisomy 19, isochrome 17, and various other deletions and additions. Molecularly, if you look at the genetic level, what happens in the translocation in chromosome 9, you have the ABL1 gene, and the translocation is usually intronic, so between exons 1B and 1A, while in the BCR gene, the translocation is usually between these three major regions, but most commonly in the capital M BCR, the major breakpoint cluster region, between E13 and E14, which helps form these hybrid mRNAs, the E13A2 and the E14A2, or the B2A2 and B3A2 respectively, which are then translated into the P210 protein, which is commonly seen in chronic myeloid leukemia. If other translocations happen, we get the P190 and P230 proteins, which are uncommonly seen in CML. So is it really important to know about this? Are there any biological differences between adult and pediatric CML? The BCR gene breakpoint is present both in the MBCR region most commonly. However, in adults, it's mostly centromeric, while in pediatrics, it's telomeric with breakpoints in the ALU region. In adults, we have data of the B3A2, the E14E2 showing faster response and better survival. However, in children, we only have information regarding its response to imatinib, which seems to be faster, with no difference in survival. I think we all know the phases of CML very well now. There are three phases, a CP, AP, and the blast phase. The chronic phase can be defined by various definitions, the cutoff being between 10 to 20%, while blast phase, the cutoff is anywhere between 20 to 30%, depending on which classification you're following. And accelerated phase, though the WHO has removed it from its classification, it does definitely still hold a lot of clinical significance in practice. And the blast count is usually somewhere in between that's seen in CP and BP, along with presence of new onset thrombocytopenia, basophilia, new onset splenomegaly, and the evolution of these ACAs on therapy. So are there any differences in presentation, adult versus pediatric CML? Just remember that pediatric CML is more aggressive. So more symptoms, larger spleen, more anemia, the higher WBC count, lesser early molecular response, more advanced disease, but the prognosis remain the same. There have been certain studies done in India which have tried to see whether the UTOS, Hasford, and SOCAL scores, which are used commonly in adult, are prognostic or not, and they've not found them to be prognostic. But recently, I think in ASH, the 2023 abstract was released where the UTOS long-term survival score was tested in over 500 children of pediatric CML. This is from the International Registry of Childhood CML. And they found most of these patients were on imatinib, and they found that low and intermediate risk patients had a better survival as compared to high risk patients. And with that, they gave a recommendation to start for high risk patient to start second generation TKIs. So with this in mind, when a patient presents to you in the OPD or in the emergency, how will you evaluate them clinically? So most importantly, I think you should ask for symptoms, which we see more commonly in our patients. Look for the spleen size, not only a diagnosis at every follow-up. Look for extramedullary disease, lymph nodes, skin, bones, etc. Evaluate for complications of leukostasis, and very importantly for children, do a growth and Tanner staging for all these children at follow-up till maturity. If you look at the investigations, the investigations are divided into mandatory and some which are optional, and I'll just be going into them. So CBC, we start with the CBC, we differentiate with preferably a peripheral smear to evaluate the blast count and basophils. A bone marrow aspirate is done to assess blasts and basophils with the presence of excess blasts, especially with unclear cutoffs, showing some benefit if you do a bone marrow aspirate. Flow cytometry is optional. And it's mainly used to differentiate between lymphoid and myeloid blast clusters, and bone marrow biopsy is also optional, which is mainly used to detect fibrosis or blast clusters. This is a bone marrow aspirate slide of CML showing wide range of the myeloid left shift along with basophils that you can see over here. So the third most important test that we do is a karyotype, which detects both the Philadelphia chromosome, the variants, as well as the additional cytogenetic abnormalities. They say at least you should analyze 20 metaphases, sometimes even more if you want to detect complex karyotypes. But in my experience, we don't really see that they do more than 20. This is a picture of a routine karyotype, where you can see this 922 chromosome on translocation. And how I remember it is I look for the 22nd chromosome, and it's usually smaller than its counterpart. And this is how a karyotype is reported, the ISCN in the current guidelines. The fourth important test is the FISH, which is usually done if the karyotyping fails. And we usually do an interphase FISH, and it's done to detect Philadelphia chromosome, variants, cryptic translocations. But just remember, we can't detect the additional cytogenetic abnormalities with FISH. But it's a more sensitive test because it can detect less than 1% of leukemic cells. So I think we know the principles of a FISH. The BCR fluorescent probe, you can see over here, is in green, and the ABL1 probe is in red. And what is formed is this yellow probe. And what you should have at least 90% showing this yellow signal, which the pathologists are able to identify and tell us. So in our center, we do a FISH in almost all patients because we get the report faster. RT-PCR is a very important test which identifies the BCR-ABL transcript and should be, because it identifies both typical as well as atypical variants if used without cytogenetics. So this is a multiplex PCR gel. On the right, you can see the controls that are present. And on the left, you can see the cases. So what happens is whatever the case is, you compare it with the controls and you get the transcript of interest or whatever is present in the patient. The RT quantitative PCR is actually optional at diagnosis, but is mandatory at follow-up because it monitors the BCR-ABL levels over time. So just remember, to send this quantitative PCR, you must collect it in an EDTA tube and it must reach the lab within 24 hours because we're dealing with RNA. And you have to ensure that adequate sample is there, and there are actually cutoffs for adequate sample. And I'd request everybody to go back and read what the adequate sample is. So what happens in this report is you basically look at the ABL, you compare the BCR ABL transcripts to the ABL transcripts, and the ABL transcripts should be a minimum of 10 raised to power 4, otherwise it's labeled as a test failure. So we look at a report, the BCR ABL quantitative international IS scale report done on a peripheral blood on a follow-up case of from CML, where they've detected a P210 major transcript. The copy numbers of ABL are well over 10 raised to power 4, and copy number of BCR ABL is around 123. So we get the BCR ABL to ABL1 ratio in percentage, which you multiply with the conversion factor for the IS for a particular lab, and you get this BCR ABL IS ratio, which is the one which is followed in, which we use for MRD monitoring. With that, we come to the management or the therapeutic goals of pediatric CML. And not only is it now cure with TKIs as the backbone of therapy to prevent any progression, but now more and more we're looking at deep and durable remissions and TFRs, which Dr. Nirmalya will be speaking about soon. And of course, as pediatricians, our focus is always on the quality of life because these are younger patients who will live their whole life on TKIs. The initial management is like any hyperleukocytosis, but CMLs don't have a very high blast count, so we don't really start them on IV hydration only unless they're symptomatic. Hydroxyurea is usually started till a WBC count of less than 1 lakh, and we usually start TKS once the BCR-ABL is confirmed. Allopurinol, aspirin are not needed unless there are features of TLS, and we should manage the complications appropriately. So what really changed the management of CML are the tyrosine kinase inhibitors. So the BCR-ABL tyrosine kinase is something which is formed by the translocation of BCR and ABL, and this molecule has an ATP binding site and a tyrosine substrate. So once the ATP binds to the BCR-ABL tyrosine kinase, it phosphorylates these tyrosine substrates, which causes constitutive activation and formation of CML. TKIs are competitive inhibitors, which inhibit the ATP and thus help in the management of CML. The TKIs which are approved for CML, which bind to ATP site, are imatinib, dasatinib, nilotinib, bosutinib, and ponatinib. And the newer TKI on the block is asciminib, which basically binds to the myristoyl pocket, and various other new drugs, which I'm sure Brigadier Kapoor will be talking about soon. So we all know about the TKI evolution from the early 1990s. The pediatric approval for all TKIs has sort of lagged behind the adult approval. And in our center, I just found out when we had, gotten our first patient being treated on certain TKIs, we started using imatinib since 2001 and followed almost 10 years later by nilotinib, and a lot of help was given to us by the Max Foundation in the initial years. And now we've moved on to using bosutinib since last year as well. So there are a few things you need to know about usage of TKI before we go on to the important thing, which is the minimal residual disease monitoring. The first thing is, how do we choose the optimal TKI? Do we choose a first generation or second generation? That all depends on what our goal of therapy is. And the choice usually lies with the physician. Most of us, I think, for pediatric CML still start with imatinib. However, just remember that second generation gives us a faster and deeper response with no real overall survival benefit. But we may consider it if the patient has a high risk on ELTS score, or if we're considering TFR, which may be spoken about later. Bosutinib is something which we can consider in pediatrics because it has now shown early trial results are that they have less growth impairment and may actually be useful as a first-line drug. Ponatinib and asciminib are still in trial phase and can be used in resistant cases in pediatrics. The second thing, which I don't think really is a debate anymore, is a generic versus branded TKI question. So I think we all know it's much cheaper to use a generic one, and the access is great now thanks to the Max Foundation initially. And now they've all been embedded into various national and state health insurance schemes. And recently, an article published by the TMH team shows that generic imatinib also shows a faster molecular response than the innovator brand. The third thing to know about the adverse effects, and I won't really go into the details for the lack of time, but just remember the ones in greens are the ones which can be managed by reducing the dose or stopping the TKI for a short time, like hematological liver toxicities, which are most common, followed by rash, muscle cramps, and other various GI adverse effects. The ones in red are the ones which necessitate stoppage of drug. So, for instance, serosal effusion and pulmonary hypertension for dasatinib, and QT prolongation and arterial occlusion for nilotinib are something we should keep in mind. The fourth and one important thing is to know about TKD resistance, or the tyrosine kinase domain resistance, which basically develops while the patient is on a particular TKI. So these are the various mutations which have been reported in literature to imatinib, and various other resistant to other TKIs which have been reported in literature. I've also mentioned them over here. One famous one is the T315I for mutation or resistance to all the first-line drug for which we use yeah. So this is the one such report, which is basically done to assess for the TKD resistance. And this is an NGS-based report, and in our center, it costs around 6,000 rupees. A Sanger sequencing can also be done, and it is acceptable to test for TKD mutations on the Sanger sequence. What we find is when you get the report, you will get this variant, and you'll get a variant allele frequency. So I just recommend everybody read the VAF. It should be more than 15%. If it's less than 15% and the mutation is reported in literature, it's fine. But if it's less than 15% and the mutation is not reported in literature, it's best to repeat the test. Once you get the mutation, I always like to find the mutation myself in the ELN guidelines or in literature to be sure, and based on the report then, change the TKI accordingly. The fifth thing is definition of response in CML. And the first thing two TKIs, and the first thing we see is the hematological response, which is usually first checked within every 2 weeks, but optimally within 3 months, where we expect a normalization of a WBC count, differential count, platelets, and there's also no splenomegaly or CML related symptoms. Cytogenetic responses are not really seen today, but just remember major and minor cytogenetic response, which should be optimal within 6 months and is done on bone marrow cytogenetics of fish. And the third is molecular responses, which are very interesting and are usually tested on the qPCR using the IS scale that I had mentioned previously on peripheral blood. The early molecular response is defined as, so all these responses are defined as log reductions. So the early molecular response is a 3-month of BCR-ABL of 1 log reduction or less than 10%. A major molecular response is a 3 log reduction or BCR-ABL of less than 0.1%, and a deep molecular response, which is needed for a TFR, is anything more than a 4 log reduction or 0.01%. So this brings us to the monitoring of pediatric CML or any CML. And I know this is a busy slide, but just remember that what we need to see are targets for 3rd, 6th, 12th month and anytime after 12 months. Remember the number less than 10, less than 1, less than 0.1 for 3, 6, and 12 for optimal response. And in such cases, we continue the TKI. If the number is more than 10 or at 6 months between 1 to 10%, or after 12 months more than 1.1%, it's probably it falls under warning or a possible TKI resistance. Or in my experience, definitely checking for compliance and drug interactions. Consider doing a TKD mutation analysis or imatinib levels. Switch to alternate TKI or increase the dose of the TKI. And just remember that the warning is once if they are in these numbers are with a declining slope. Failure is usually defined if at 6 months it's more than 10%, or after 12 months it's more than 1%, or there's development of high risk ACAs. Here also you must check the compliance. Doing a TKD mutation analysis is mandatory, and we also switch to an alternative TKI, and here we plan for HSCT. There are a few interesting points. Don't rush to change treatment at 3 months if it's more than 10%. Wait till 6 months. Some patients actually can improve. Do a mutation analysis if there's loss of any of the milestones, rising transcript levels, or progression. Use extra tests like cytogenetic analysis or myeloid panels if you're suspecting a clonal evolution. So just briefly on TKI switch, apart from primary resistance, secondary resistance, which is loss of prior response, intolerance, progression to advanced phase are also indications. TKD mutation analysis is necessary. If the patient fails, this is something which I found interesting. I'd be really interested to know what our experts' opinion on this is. If the patient fails to a second generation TKI, even if the mutation suggests a sensitivity to another second generation TKI, it's better to switch to a third generation TKI. Also remember that a lack of a DMR is not itself a reason to change therapy. And whenever you're switching early, be very cautious because sometimes the BCR-ABL levels actually decline. So the TKD resistance analysis, just remember that we are doing it for the ELN-defined failure or warning whenever the IS ratio is more than 0.1. Other cases are if the patient loses MMR post-HSCT, or if the patient is on a third-line TKI therapy and there's no improvement or worsening, or if there's no response even after you switch a TKI, you should do a TKD resistance analysis. So lastly, I'll talk about chronic toxicities, and a lot of work has been done by PGI itself, where we found that usage of imatinib has led to significant growth reduction, mainly due to the affection of the growth hormone IGF-1 axis. And treatment of growth hormones actually led to an improvement in growth velocity and normalization. This also has been done by the PGI team. Other chronic toxicities reported in Indian literature are also bone health issues, delayed puberty, fertility issues, other endocrine issues like hypothyroidism and immune abnormalities. Just one word on CML advanced phase. Accelerative phase are usually managed by second generation TKIs, and the prognosis upfront is similar as that is with CP. Last phase, usually in pediatrics, it's lymphoid phenotype, and we always have a difficulty differentiating it with the Philadelphia positive ALL. We use intensive chemotherapy with TKI, and the TKI we use is a second generation TKI. And we usually proceed to HSCT in these cases, as well as those who are on chronic phase failing 3-4 lines of TKI. We usually do it in a second CP, and MSD or MUD donor is used. Myeloablative conditioning is preferred. Reduced toxicity regimens are showing promise. The debate now is on what is the stem cell source we should use and how long the TKI, or should we use a TKI post-transplant, if at all. So this is my last slide on my institute's 20-year experience on using imatinib, which was published a few years ago in IJMPO, and where we had around 95 pediatric patients, almost 95% of them going into CHR, with around 65 to 70% going into MMR with an overall survival rate of 80%, and which mimics most of the overall survival rate. Don't bother about the EFS. The EFS, the definition for event is completely different in all the studies. But this slide is a testament to all the efforts made before we could have this discussion, very fruitful discussion today for the management of pediatric CML in India. Thank you. Vinay sir.
Thank you, Gargi. Thank you for such a lucid presentation, and very happy to see the evidence from India. The last slide was very inspiring. So now I would just open for a panel discussion, a very quick panel discussion with two cases that Gargi would present. Gargi, back to you.
Okay.
We invite panelists Dr. Deepak Bansal, Brigadier Kapoor, and Nirmal Sir. Please join and probably discuss with your inputs.
So other people can also post questions. We can ask those questions at the end. But I'll just discuss two cases first. So this very quickly is a 12-year-old girl who had presented with CML, intermediate risk on ELTS type, with E4A2 BCR-ABL transcript. She was diagnosed with on a peripheral blood sample outside. So you can see the IS ratios after starting imatinib she'd almost gone into she was in a deep molecular remission, but she lost it at around 1.5 years, and where we found a compliance issue, which is very common, after which we restarted the imatinib, and she's done actually quite well following that. So check compliance every time. But with that, I want to ask a few questions to our panel. So can we diagnose CML on peripheral blood only, or is a bone marrow necessary? And which cutoff do we use? ELN, ICC, WHO? And what are the tests you recommend to do up front for patients, especially in resource-limited settings? And maybe Dr. Deepak can take it up first, followed by Brigadier Kapoor and Nirmal Sir.
Thanks, Gargi. Am I audible?
Yeah.
Yeah, so like you've already shown us quite a bit of this. So yes, CML can be diagnosed on peripheral blood, but a bone marrow is always done, because I think if you look at the table of definitions, the cutoff now, the WHO cutoff is 20%, and it says in marrow or marrow and or peripheral blood. So I guess we need both to be sure whether it is chronic or blast phase. because accelerated is out now. That's a new learning for us. That there is no longer accelerated phase as far as WHO classification is concerned. So yes, we have to do both peripheral blood and marrow to be sure which of it is. Second is, which cutoff do we use to define chronic phase? So, I'm not too sure about this answer, but I guess now that we have the WHO, so we should be using it. If you ask me, what is the point in knowing whether it is accelerated versus blast crisis? So, in some of the patients in whom transplant is not easily accessible, I know there are case reports in literature wherein patients with accelerated phase have kind of done okay with TKIs alone. That may not be recommended, but few patients have done okay with TKI alone in accelerated phase. But I guess if it is WHO, then one should be following that. But I would really like to know what Dr. Kapoor thinks about that. So tests recommended upfront, you've already answered. Karyotyping should be done, but often it is not available or it just does not show a report. FISH, of course, is easy. RT-PCR is necessary to do transcript. Of course, quantitative PCR is not really needed upfront. That is needed more for follow-up. Thanks.
Yeah. Kapoor, sir?
Yeah, thanks, Gary. Excellent, lovely talk. So I do agree with most of what Dr. Deepak has said. Only for the first question, yes, we do recommend bone marrow necessary. In addition to what he said, two main things which we want to pick up is what you had mentioned, additional cytogenetic abnormalities, which probably we can't pick up on peripheral blood, which is a very important marker. The other thing is the bone marrow fibrosis we always assess, because the patients who have fibrosis generally do not tolerate the full dose of imatinib and they go into cytopenias very soon. So we have to monitor them more closely. So that's why we feel that the bone marrow is necessary at diagnosis. And second question, I do agree with Dr. Byak. We do follow WHO because we've now been following for all the myeloid. So I guess the cutoff what we use for the blast still remains 20%, and they have done away with accelerated phase, which I think it's okay to do it. So we are following WHO, not ELN or ICC. And the test we recommend to do upfront, yes, we do karyotype and RT-PCR. And in some cases, we have started doing qPCR also, because there is some data which is being generated. If there is a faster response, the decline in the BCRE will, in fact, if we do it at 1 month and much earlier than the 3 months, we know that they are going to do better. But that said, it is more for the adult, and as you had pointed out, in pediatric we have also seen that the response is actually later than what we see in adults. So that's my take. I think there was one question in the box which said that for response assessment, do we do bone marrow? Absolutely no. If a person has, if the patient has achieved a complete hematologic response, spleen has gone, so we can monitor by peripheral blood only. At that time, we generally do not do bone marrow. Marrows only we do if we think that it's progressing on to a blast crisis or something.
Sir, and one other question is, what about the NGS that is now done for those additional mutations? Do you do it upfront
Right.
in your young adults cohort, or?
Yeah, so that's, I think there's a couple of slides in my presentation about
Okay.
that. So that's
we'll
very
get into that.
exciting.
Yeah.
I think we are inching towards that right now. The answer is no, but I'm sure probably I'll discuss. I think we are inching towards that time, I guess.
Okay. So we'll discuss the second case and we'll get Nirmalya sir's input on that as well. So we have a 16-year-old boy diagnosed in May 2023, again, who was a CML, but an ELTS high risk at this time. His karyotype, some things shows 40, the 922, and some had actually hyperdiploidy. And the B cerebral transcript was an E14A2. This child actually had TLS and fluid retention also at admission. So this patient achieved CHR at 3 months. After that, you can see that his B cerebral IS ratio was never really reaching any targets. And at 1 year, we did an IRMA analysis, which showed a mutation to resistant to imatinib. And then we switched to dasatinib, and we continued the patient on dasatinib. We started at 50 and we could increase till 75, and we sort of continued at 75 because he achieved an MMR. So loss of CHR, be wary of a TKD mutation. So just wanted to ask, like, when should we send TKD analysis? Is there any data to send TKD analysis upfront as well? Maybe in some CPO, especially in cases of de novo blast phase, and use ELTS scoring for pediatrics. I mean, and start second generation TKI for them. And the third question is regarding the dose of these TKIs. Can you start a lower dose and then go up, escalate up? Anybody wants to take? Nirmalya, sir?
Yeah, am I audible, Gavi?
Yeah, audible.
Yeah, so coming to your first question, when should we send TKD analysis? We don't send it upfront in cases of CP, but for patients who have more advanced disease, we do send upfront because, I mean, that might as well be helpful to choose the TKI, I mean, of those we have access to. And regarding use of ELTS code and deciding on your second generation deciding on your TKI upfront based on ELTS code, you have seen the international guideline that has come this year, and they recommend that for ELTS high, it's better to start a second generation. The EFS was significantly low in patients who had high risk. But I mean, as of now, in our practice, we have not started doing that, but the evidence is quite compelling. I mean, maybe we'll also switch over to doing second generation for ELTS high.
Okay. Deepak sir, Kapoor sir, any difference in opinion?
Absolutely, I do agree.
जो कोई नहीं पाछड़ नहीं बना next slide swing वक्त है
I request everybody to mute their mics except the speakers. Yeah. Yes, sir.
Yeah, so the same thing for both the questions and answer remain same. And yes, we have started using the second gen TKI for the patients who are high risk, and ELTS we are using because of the compelling data which he had said. And regarding the third question about the dosing which we do, so now in young adults and adults, we had one prospective study called GLAD study through HCC where we have used 50 milligram dose. Now, what it says, it's as effective as the higher dose, but only in the we had used SOCAL in that and low to intermediate. The high risk SOCAL unfortunately do not do well with a lower dose of dasatinib. And as you had mentioned in your slides, that most of the pediatrics and the young ones actually, when they come to us with a huge spleen and the counts, they generally tend to be higher SOCAL and even the ELTS on the higher side. So we still have to look in the data whether we can cut down on the dose of dasatinib upfront with a high risk patients. As of now, we are using the full dose of dasatinib in high risk patients as such.
Okay. So dose reduction only for dasatinib. You imatinib usually start with, we don't go below 400.
Yes, we don't.
And nilotinib, still no data.
Yeah, that's it. So one thing about the cytopenias, the initial cytopenias, they do tell us that they are more sensitive to the TKIs, but as your patient had developed cytopenias later on, that indicates that they are going for the resistance and better to change to the other generation of TKI.
Yes.
Yeah, just to add to that, Gargi, I mean, I think as pediatrician, most of us are not used to doing ELTS scoring upfront. So it's a very simple online tool. One can Google it. One gets the online tool. One has to put in the age, the blast count, the spleen size, and there is one more. I'm forgetting. I think
spleen, blast count, and I'll put it on the group. Yeah.
And 10% of the pediatric CML patients will have a high risk. And as Nirmalya said, the guidelines have now suggested using second line. And the generic dasatinib, if I understand correctly, is actually now cheaper or more or less same price as imatinib.
Absolutely. So there are many brands coming and they are at same price as imatinib.
Yeah, so previously we were least concerned because, we had access only to imatinib, but now the cost of dasatinib and imatinib is the same. So one could consider it, although there is no, nobody has really shown that the final survival will be better, but it's something to really consider. Yeah, thanks.
Okay. So it's age, spleen, blast percentage, and platelet count. for everybody. So I'll
one quick thing before you wind this up. So regarding your previous question, so doing bone marrow at baseline. So bone marrow can be aspirate and biopsy. So I mean, previously we were doing both. Even now we do in most of the centers to pick up blast crisis. As you know, in the initial definition of blast crisis, we had clusters of blasts in the bone marrow biopsy. But then now, as per the international guideline, you don't need to do a biopsy because they have studied their cohort and then they hardly found any case which was diagnosed as blast crisis based on a biopsy. But aspirate is mandatory at diagnosis for to pick up the ACAs and of course myelofibrosis and all that. But then again, Dr. Rajan referred about myelofibrosis. So in the international cohort of children, I don't think they found too many cases. So
fibrosis. Yeah, it's very uncommon also, I think, in
it's
our
most
clinical practice. Yeah. Okay. So thank you. And if we have time, we'll take the other questions after the other talks.
Okay. Thank you, Dr. Gargi, for moderating the panel. So we'll move on to the next talk. Dr. Nirmalya would talk about treatment-free remission in pediatric CML. Is it a possibility? And sir, over to you, Dr. Nirmalya. You can take over.
Yeah. Can you see my screen?
Yeah, screen is seen, not in slideshow.
Yeah. Let me put it on presentation mode now.
Yes.
Yes. So I have been asked to talk about can TFR be a reality in pediatric CML? In the next 7 to 10 minutes, I try to cover that. Give me a second. Yes. So yes. So TFR has now become a standard goal of therapy in adults with CML. And of course, there are a lot of benefits of TFR that have been shown in adults, including reduction of long-term toxicities, improvement in quality of life, and of course, lower treatment costs. However, data in children is scant. We have had some initial reports, I mean, pre-2020, very few though, which showed that the success rate of TFR in children were inferior to that of adults. But more recent data that we have in the last couple of years have shown that success is almost comparable as compared to adults. However, there is a question of doing TFR in LMIC countries because of course, the high frequency of monitoring that is recommended by the international agencies. Of course, again, coming to the reliability of reports, unless the report is very reliable, it's a bit tricky to stop TKIs. And again, many patients do not turn up on time, so loss to follow-up can be potentially hazardous in such patients. So, till now, prior to 2024, we have got some 4 or 5 studies that have been published in the setting of TFR in pediatric CML. And as you can see, the numbers are really low. If you can see my pointer, most of those studies are retrospective, starting from the international registry to the STOP IMAPET study. All of them were retrospective. The only prospective study that we had till 2024 was the Japanese study. And of course, you can see one study from Apollo Chennai, which was also a retrospective study on a very less number of patients, but again, something from India to talk about. And of course, the success rate of TFR was quite variable in these studies, ranging from close to 30% to 72%, as high as 72% in the Chennai study. With this background, I'm going to talk about our experience of trying TFR in children with CML in CP from our pediatric CML cohort at Tata Memorial Hospital. It's a prospective study which started in 2020. So all children who were diagnosed at less than 15 years of age and were getting treated with us, having satisfied these 3 criteria of having imatinib for more than 3 years, with a persistent deep molecular response or MR4 for more than 2 years. And of course, they have to be willing for regular RQ-PCR visits. As you know, we see patients from all corners of the country. So following up on time becomes a real issue. So, it has to be really well planned and agreeable to the family that they will have to have more frequent visits. So initially we set out to actually make the monitoring schedule quite realistic for our setting. I mean, we were unable to offer 1 monthly follow-up and RQ-PCRs because people can't travel, and of course, outsourcing to local labs was not an option given the unreliability of the results that the local labs generate. So we started off with 3 monthly RQ-PCR initially, but later on we changed the first RQ-PCR to 2 months, and thereafter all RQ-PCRs are being done every 3 months. So coming to failure of TFR, patients who showed 2 consecutive rising transcript levels over MR3 were considered as failure of discontinuation and restarted on imatinib. However, I must say that for patients whose who would have very high transcript levels, more than 1%, we would not go and repeat the RQ-PCR in 4 weeks, but restart imatinib then and there. So coming to the follow-up schedule, as you can see, patients would get CBCs and RQ-PCRs in all visits. The first visit at baseline, followed by month 2, 5, so second month, and then 3 monthly for 2 years. And we would also request for an additional CBC from a local lab while they are away for the first 2 months after 4 weeks interval from stopping the imatinib. This is just an additional safety net. I mean, it's probably more for our satisfaction than anything to do with the biology of the disease. But then again, we did that. Coming to statistical analysis, we used conventional statistics to present the clinical data. TFR rates were estimated using the Kaplan-Meier method. We also calculated cumulative incidence of loss in MMR post discontinuation and gain of MMR once imatinib was restarted using the cumulative incidence function, accounting for competing events. Analysis was mostly done in SPSS software as well as R software. So coming to the study flow diagram, so till I think 3 months ago, the last data cutoff was in February 2025. We have got 195 patients in our pediatric CML CP cohort of Tata Memorial Hospital. Of them, 62 patients were eligible for discontinuation as per the criteria that I had mentioned in the method slide. Of whom 59 patients agreed to participate for this discontinuation trial. I'll come to that, but I mean, offering discontinuation to such patients who are on imatinib for a long time actually is viewed, I mean, as a fantastic opportunity for most of the patients. I mean, I've seen very few families refusing this. And again, we had 2 patients with CML AP as per the previous criteria. Their blast counts at the time, blast percentage at the time of presentation were some 12 or 13%, and they did, I mean, beautifully well after starting imatinib, went into deep molecular remission, remained so in DMR for, I think, one was having DMR for 7 years, the other was having for close to 10 years. So they kept on requesting, and we finally agreed to stop imatinib for them as well, warning them well ahead in time that chances of failure are high. So 61 patients eventually discontinued imatinib, 38 patients till date remain off TKI, and 23 patients lost MMR and were restarted. Baseline characteristics, I won't go through the details, but then the median age of the patients were around 11 years. And median age at discontinuation was close to 20 years. I mean, I just wanted to mention that these patients who were diagnosed as pediatric CML when under 15, they continue to follow up in our clinic because whenever we ask them for a referral to the adult side, they would just not accept that. Median duration of, but of course, I mean, we discuss difficult, sort of adult cases with our adult colleagues. But then the follow-up is predominantly with us in the pediatric CML clinic. So median duration of follow-up was 28 months at the time of the last data cutoff, which was in February 2025. Mean time in major molecular response and deep molecular response were over 6 years and 4 years, respectively, for these patients. So now coming to this survival curve, as you can see, TFR rate at 12 months, that is 1 year, was 68%, and at 24, it was 64.5%, which amply highlights that most of the events or most of the loss in response actually would occur initially. That too within the first 3 to 6 months of discontinuation, which corroborates well with the literature that is there. And this again shows just the reverse of this. So cumulative incidence of loss in MMR were just over 30% at 12 months and 35% at 24 months in our cohort. And this shows the RQ-PCR trend in the 61 patients. This is nice spaghetti curve actually makes a lot of sense, because you can see all the chaos between 0 to 6 months, and then the sort of situation settles over further follow-up. So this just tells us that most of the events occur early after discontinuation. So withdrawal, we saw mild withdrawal symptoms in just over 10% of our patients, which were manageable with occasional acetaminophen taken over the counter. So as I say, 23 of these 61 patients who discontinued were restarted on imatinib, same dose as prior to discontinuation. At a median follow-up of 22 months, 17 of these 23 patients have reattained MMR, and 10 have reattained DMR. The gap between 17 and 23, which is 6, these patients are actually within the first year of restart. So we are yet to see what they do in the future. But we are very hopeful that this patient will also go into MMR sooner or later, hopefully sooner. So coming to the cumulative incidence of regain of MMR, as you can see, within the first 1 year, 3/4 of our patients would regain MMR after having restarted imatinib post failure of discontinuation. So what are the benefits of TFR in our patients? It's not only about getting off the drug, but what was also very striking in our cohort was that some of the off-target TKI toxicities were actually reversible. For example, bone health that was assessed at baseline before discontinuation, and for patients who were on discontinuation successfully over 2 years, they had significant improvement in the bone health DEXA scores. I have not shown the data because of interest, in the interest of time. And also we have recently started doing a psychological study or assessment for these patients. And this study actually remarkably shows that there is a definite positive psychological impact in these patients. So the data that I have just shown, a part of it was published last year in American Journal of Hematology. And I would conclude from this study that TFR in pediatric CML is feasible and safe, even in the LMIC setting. And our cohort represents the single largest cohort of pediatric CML TFR that has been published till date. I'm aware of the COG study that is ongoing on TFR. They have also accrued close to 60 patients, but they haven't published the data yet. High rate of TFR was documented. This is comparable to any adult data. 3/4 of patients who failed discontinuation and were started on imatinib regained MMR by 1 year of restart. Long-term TFR was associated with improved BMD, bone health, as well as had positive psychological impact in our patients. And we can actually now say that trial of TFR under controlled conditions should define the new goal of therapy in pediatric CML. And I'm glad that the international panel recommendations that came out last month has actually agreed to include the idea of TFR in their guideline, though they say that it has to be under strict monitoring, preferably in the setting of a study. But then, of course, till now, we didn't have any clear-cut recommendations about that, but now it's in black and white. So what is there for future? We are actually planning a multi-center national study under the aegis of INFOG to test TFR in pediatric CML. We have named it STICK CML study, stopping TKI in Indian children with CML in chronic phase. I've submitted the study for INFOG registration, and I'm sure there will be quite a few interested centers. If you want to contact me, please contact on this email ID. And once we are ready with the study, we'll get in touch. Thank you.
Thank you, Dr. Nirmalya, for that talk. And I think we were all, very curious to know about the results from TMH. And, that's what our patients also keep asking, can we stop the drug? And we have some answers from our own country now. Next, we will take the questions at the end of the session. We have a lot of questions in the chat box also, so we'll come back to you. And now we move on to our next speaker. That's Brigadier Dr. Rajan Kapoor, who's professor and head of hematology at 153 GH Lay. Dr. Rajan Kapoor, please correct me if I've not, said anything correctly.
No, no. Yeah, I'll just try to set it up.
Yeah.
And Shruti, I just wanted to make a comment that, we are really thankful for Brigadier Rajan to join us because, while we were planning this session, we wanted to have an adult perspective as well, because most of the knowledge for CML we have learned from our adult colleagues who see this disease much more than what we do. So Dr. Rajan is an expert in this area, and we thought it would be great if he could join us. And he's right now in Leh, and he's online. So thanks for doing that, Dr. Rajan. Thank you.
Thank you so much. Am I audible and is my screen visible?
Yes, that's
Yes,
First of all, thanks a lot. It's really a matter of pride and honor to be part of PHU, and this is a fantastic learning teaching platform. I'll make sure that I keep attending these meetings in future also. So right now I'm at Leh and enjoying the summers here, and I'm sure people in Delhi and Chandigarh must be sizzling hot. So the topic which has been given to me is CML recent advances and emerging therapeutics. So thanks to the previous speakers, it's fantastic learning for me from first and the second speaker. So I'll just give the adult perspective and see how we can adopt in the pediatric setting. So when I started preparing, there was a timeline graph shown by Dr. Gargi also. So I said I'll sit and make it myself. And now, if you see, CML has been the disease which actually opened up the treatment to say the targeted therapy, the magic bullets, and the first cancer to show the Philadelphia chromosome. So as you see in this graph, we started in 1960s, but now it's going so fast. It's not only the therapeutics, it's the diagnostic, it's the guidelines. CML is probably the in cancer which has got the maximum guidelines which were discussed. So we are going in a very fast direction in CML. Now, this is what we did as a part of HCC. We did try to study the outcomes of young CML treated with TKI. So we are in the process of writing it up. So there were more than 1,000 patients almost, and 273 of them were adolescent and young adults. So what we found in is that one is what had been addressed in the first talk, that adherence is an issue and delayed achievement of molecular response. Now, if I have to point out what are the challenges in 2025, so the major challenges in CML, which we feel as one is the resistant and the infamous T315I, the intolerance and the chronic toxicity, because CML has become so amenable to treatment that it has become a chronic disease, the cardiovascular risks, adherence, and treatment fatigue. So for the students who are there in this lecture, if someone asks you about the TKI resistance in CML, so we do have BCR-ABL dependent mechanisms, which are the mutations, or they can be amplification or overexpression. But there are a whole lot of BCR-ABL independent mechanisms, which are very interesting, which I'll just allude to in my concluding slides, which can be activation of signaling pathways, increased drug efflux, epigenetic changes, genomic instability, and so on. Now, the mutations. There are a whole lot of mutations which are there, which are now easily picked up on NGS or Sanger sequencing. The most infamous of them is 315I, which is the major issue when we treat. And the ballpark figure of all studies, if we see, almost 30% of them, starting from the IRIS study and onward, do develop resistance down the line. Now, this is the chart which I always keep at my desk, because there's so many mutations which are thrown at us after the NGS, that we should know which mutations, which is the best TKI which we can use. Now, this is a slide which I prepared. There were two major studies which were done. One is ENEST which was with the nilotinib, and the decision with the dasatinib. Now, if you see the uh, major cause of mortality, since it has become a chronic disease, now if you see the CML related versus non-CML related deaths, and if you see the total deaths in this bar, it's almost the same whether you use imatinib, nilotinib, or dasatinib. The figure is 10 to 11%. But what is concerning is non-CML related deaths, which are strikingly higher in nilotinib compared to imatinib remains the safest one. So this is very important when we see the extreme of ages, even in the pediatrics, as we know, uh, when we start a child on a TKI, actually we tell the parent that it is going to likely to be lifelong. So this becomes very important to know about the non-CML related deaths, which unfortunately are more common in second generation TKIs compared to imatinib. This has been already shown, so I won't waste my time. So now these are the targeted therapies which are available to us. Now I'll just start with a case which I think all of us can relate to. 11-year-old boy, high ELTS score. It's a school-going football player, so we know how at this age children are very active, always hungry, try to eat. You can't stop them from taking mid-meal snacks and all that, which has to be kept in mind. ELTS, as has been brought out, is a key predictor, and as has been told by Dr. Deepak, we should be using it, a very simple online calculated. And as Dr. Nirmala had already said, now our goal in pediatric is TFR. So this is what we have. So if you have, now we have generics of imatinib, nilotinib, and dasatinib, and with a comparable cost. So what should we do? Imatinib, yes, we all know, well studied, good availability, lower cost. But the problem with imatinib is it does lead to cramps, myalgia, and may limit physical activity, which is a problem for our football player. Nilotinib is deep response, but biggest problem with nilotinib is twice daily adherence issues. You have to have a 2 hours before, 1 hour after. Telling it to a child would be very difficult. Dasatinib is once daily, better tolerated. Pleural effusion is a risk, but very rare in children. So if you ask me why dasatinib is a preferred choice, once daily routine, supports the school routine and football activity, no food timing restriction, lower musculoskeletal toxicity, and maybe molecular response. So that's how we probably are going to choose the best TKI in pediatrics. Now, coming to what is new and what is available to us, this is the main thing. The new kid on the block is the STAMP inhibitors. Two major trials of asciminib, ASCO first, which I'm going to talk about, and then there is CML13/Ascent. Now, if you ask me in one slide, frontline CML, what are the practical applications with availability? Now we have 5 TKIs which are available now, as Dr. Gargi had brought out. Now we have started using bosutinib also in pediatrics, and too early to say, but very small numbers, but that's also available. It's frontline TKI choice by ELTS, comorbidity, and TFR goals. Now, lower dose, there's a lot of interest in second generation TKIs, whether we can use lower dose of bosutinib or dasatinib. ASC4 first has shown asciminib. And as the question was asked, whether we are going towards an era where we can do a genomic profiling at diagnosis, we can personalize TKI choice. So I'll just run through the ASC4 first trial. This is a very interesting trial in which asciminib was compared with investigator-selected TKI, which was imatinib, dasatinib, and nilotinib. Now, this is a first-in-class STAMP inhibitor. It causes allosteric inhibition distinct from ATP-binding TKIs, and it is active against many resistance. And most important for us in India is it does have an effect against T315I. So it did show superior MMR, improved tolerability, and this is the first trial to show superior efficacy of a STAMP inhibitor of first and second gen. So I just put together all the things in this bar plot. If you see, MMR was more than any of the investigator choice TKI at 48 weeks, MR4, and very interestingly, the grade 3 adverse events were much less than the other TKIs, and the discontinuation rate was. So it all looks very good. better, more effective drug, lesser toxicity. So it may become a preferred frontline option, better safety profile, and patients with intolerance or high cardiovascular risk, we can use it. Now, if you go with the approvals, it has been approved with T315 mutation after failure of one prior TKI or after two TKIs. The dosing is very important to understand. It is 40 milligram BD in without T315I, but the moment it becomes 315I, it is 200 milligram twice daily, which is something to ponder about. Now, mode of administration, again, this is a problem in pediatrics because it has to be taken on an empty stomach, something like nilotinib, and you have to avoid uh, the pentoprozoles and omeprazoles and CYP3A14 inducers. Now, you have to monitor for pancreatitis, QT prolongation, something like a nilotinib. So, the practical tips is use in second line for second generation intolerance. Always confirm 315I mutation because the dose is much more than the normal one. And counsel on adherence, side effects, and financial support programs. Now, what are the pediatric challenges? It's not approved as yet for pediatric. There is a limited data from the trials, and the challenges are there are no formulations, dosing complexity, delayed access. The major issue is a financial toxicity. Now, a word about AS4 Kids, which is just going on phase 1 to 2, and they have taken 30 to 40 pediatric patients. Now, they did have mini tablets and dispersible tablets. Now, preliminary results do show around 50% going to MMR, which is comparable with adults, even in heavily pretreated patients. Safety profile is mostly tolerable. So, this is something which we may use in pediatrics because if we have T315Is, this is one option which does exist. But the biggest thing is the high cost. Actually, the Kaizefic, the trade name, also has an elephant in it. It's too much. 200 milligram BD to afford out of pocket is next to impossible for most of our patients. Now, the other word about the ponatinib, again, it's a third generation TKI not approved for the pediatric use, but there are only the case series and studies which have used in pediatric CML. We also have used in a couple of patients, pediatric. Now, this is an ongoing study which I just went through while preparing for this lecture. So, this is going on with the pediatric population, the ponatinib. Now, there are two publications which I went through. Again, same thing. It does have an effect, but the main problem with ponatinib is the toxicity. The vascular and the hematologic toxicity is much more than the other TKIs. The common regimens of 15 to 30 milligram daily. So it does have an effect, but it's too expensive and not readily available to us. Arterial occlusion is a major problem with ponatinib, very high cost. Just reserve it. I think the only scenarios which I see practical applicability is the patients who have to undergo transplant as a bridging option we can start. A word about the China is not in flavor nowadays in India, but this is a compound which has been developed and used in China. That is olvermapatinib. It's a third generation oral TKI. It can be used in T315I population. Again, same result as ponatinib, and safety profile is generally better than ponatinib. It is not, there are no pediatric formulation, but there are certain case studies, but it's an alternative which may be looked at. Now, a word about this was just alluded to, is allogenic for the transplanter among us. CML is one disease which has got the best graft versus leukemia effect. If one disease which can be cured by transplant in hematologic cancer, that is CML. But we know all the complications. So if you have to sum up in one slide, what are the pros and cons? It's has a potential for cure, durable remission, and pediatrics. It's very difficult for a child or a parent to be told that some drug has to be taken lifelong. So this gives a time bound treatment, and with the advancement in techniques and GVHD prevention, we generally have a very good cure. But as has been brought out, we hardly do transplants for CML nowadays. Major issue is GVHD, and though it was shown in slide like mud, also we haven't done CML other than a matched sibling donor. It's TKIs need to be continued even after the transplant. We do continue for 2 years, but there is no correct answer how long do we need to continue that. So that's a problem with LOHSCT. Now, what are the emerging therapies and future directions is asciminib. Now, the main thing what the studies are being done, asciminib plus the conventional TKIs, because both have got a different mode of action. So there are trials of nilotinib with asciminib to get a faster response in a newly diagnosed CML patient. Now, there are non-TKI approaches, JAK2, PI3K inhibitors, epigenetic modifiers. Now, gene editing is coming. Now, this is the last one is this compound bexmarilimab. I'm very sure that in myeloid malignancy, we are going to see it more and more often. Now, this is a receptor called CLEVER, common lymphatic endothelial and vascular endothelial receptor, very aptly named as CLEVER, because CLEVER is the one which the cancerous cell or the CML or any other myeloid cancer cell, they evade the tumor microenvironment. So the moment the bexmarilimab blocks these clever antibodies, there is an immune activation and that goes against tumor. So there's a recent paper in AML which has shown a very encouraging response, and there are trials going on in a CML in advanced stage. Now, the just one slide, I mean, slide which we cannot do away with are the diagnostic advances in CML. The one thing which has come as a main thing is the digital PCR. And just the infographic which I've made with an AI, this is a digital PCR. This is called a digital droplet PCR. Sample is partitioned into thousands of droplets for PCR amplification. The major advantage is it does not need any comparator curve. It has got much more higher sensitivity. So this is very important when we are considering the TFR. So if we have this droplet PCR and we really know that it's less than 10 to the power minus 6 and all, we will be more assured of doing a TFR. This is the thing which are getting developed, digital droplet PCR. The other thing is NGS. Now, a lot of questions being asked whether we should do upfront NGS to pick up. I think we are inching towards that. Now we have quantification of transcripts to know early relapse detection, and NGS panels guiding frontline TKI selection. So if we have 5, 6, or 2, 3 more TKIs coming in the near future, probably we'll be having NGS panels deciding. Now AI is coming in a big way. AI I've used for making my slides also. The models, they predict relapse. So there are algorithms now, risk stratification, ELTS, and AI overlays which are available, which will be the future. And the main thing is the personalized medicine and CML. What is the TKI choice, the dose optimization, real-time monitoring, and genomics and proteomics for tailored therapy. Now, the word about this is very interesting. Last two slides again. What is the metabolic reprogramming? Now, this is a famous Warburg theory. They say that in cancer cell, in the presence of glucose also thrive. That is aerobic glycolysis, where the normal cell use OXPHOS or oxidative phosphorylation. What happens in CML leukemic stem cells? So, one point to remember is no matter what TKIs we give, we haven't been able to target the leukemic stem cell. So that is the one which is responsible for the relapses. So that is one which is targeted by the BMT. Now CML cells use OXPHOS. So if we can target this OXPHOS, probably we'll be able to use it. Now I always feel, I think TMH has also done a lot of things. We have to repurpose the older medications. We can't keep on giving newer generations. So this is very exciting uh, data which is coming actually in AML. The CMC Vellore is doing the same thing. If we can target OXPHOS in AML, then we may get better responses. The same thing, there is some data which is coming, the TJ cycline, which blocks the OXPHOS, which may help in combination with TKIs. So to summarize, TKIs remain central. Precision medicine, mutation specific therapy are becoming a reality. Pediatric CML challenges, limited data access, and formulation barriers, which is the major problem when we give any of the TKIs, be it dasatinib, nilotinib, or the newer ones. They are metabolic vulnerabilities. In future, we may be able to target, and it is entering a personalized era. We may see combination therapies as in other cancers in CML too, because asciminib and nilotinib seems to be a very promising. CRISPR is already there. CAR-T, I'm not very sure when it's going to come. And the future of CML care is in smarter, tailored biology-driven strategies. So the Indian imperative, I'm so glad, and it's fantastic to see the data which is coming out of India from now, be the TIFIA, the largest study, what Dr. Nirmala said. We have to have collaboration across centers, pool the data, identify gaps, and if we want precision medicine to work for India, we need precision data from India. So this is what my AI assistant gave these four summary things. It's precision will buy us cures, and we should be looking at cure and eradication of CML in current era. So with this, I have ended, and I really thank Dr. Manas for initiating me into this platform, and happy to take on questions if there are any.
Thank you, sir. Thank you very much. Learned a lot of lot more. There is a lot more to learn in CML, is what I understood after listening to the talk. Thanks a lot. So we have few chat box questions that Gargi has compiled. Quickly, Gargi can run across to each expert so that we end up answering those. Gargi, over to you.
Okay. So I'll just the first question I'll ask to Nirmalya sir about the TFR. So is the goal of TFR now for all pediatric patients? And were the risk factors for TFR looked into in your study? And for TFR, do we start second generation, or can we also do with starting first generation TKIs upfront?
I mean, too many questions in the same go. So I'll take them one by one. Maybe the last question first. So whether to choose a second generation TKI over a first generation TKI for TFR. So the major benefit of bringing about TFR in children is to try and avoid growth retardation, right? I mean, that is one of the major concerns for chronic TKI users. But it has been shown that the growth retardation actually, or growth, whatever, deceleration actually takes place in the first year of TKI use. So, I mean, aiming at TFR within a year is not a possibility at all. So, I mean, we don't see any reason why imatinib would be, I mean, if imatinib is continued for 2 more years, then dasatinib, why it would be inferior choice when we are looking at the long-term benefits of TFR. But having said so, with this theory only that TFR and milestones can be attained earlier with the use of second generation TKI, COG now prefers using a second generation TKI upfront. However, the European group differ. They actually would start imatinib only for most of their patients until recently, when the high risks are started on dasatinib. But then, having said so, in India, we have most of our experiences with imatinib. They are very well tolerated. We have used dasatinib in quite a few patients now because of some reason or the other, but not upfront. But I mean, in my personal experience, imatinib is better tolerated as regards to the acute toxicities and the monitoring frequency as compared to dasatinib. I mean, I don't have a clear answer whether to use second generation, but then I just narrated what my thoughts are and what people think worldwide.
If I may ask question to Dr. Nirmala.
Yeah, who is this?
Yes,
Yeah, Dr. Rajan
Dr.
Kapoor.
Rajan.
Yeah.
Sorry.
Fantastic talk. I mean, it's really impressive to bring up such kind of a data. I just wanted to know two things. One, what happened to those two accelerated phase which you did, which was a very brave decision.
Yeah.
And the second one is, was there any patient who was initially on imatinib, shifted to dasatinib, and you took up for TFR?
No, so in this study, we do not have any patient who was on dasatinib, I mean, upfront, but there
Okay,
was only one patient who was shifted to dasatinib
yeah,
because of intolerance.
right.
Intolerance to imatinib. That's why dasatinib was given, not due to imatinib failure. Again,
Right.
imatinib failure would become a contraindication to
That's
try
what.
TFR,
Yeah.
right? So we didn't try that. One patient on dasatinib, that too due to intolerance. And the other question, AP, yeah. So I mean, of course, that was a bold decision. Actually, one of those patients, of those two, had a recurrence within the three. I mean, first RQ-PCR only showed rise, so was started back on imatinib. The other continues to be in remission now. It's going to be her 9th month assessment next month when she comes.
Great.
So fingers crossed. Let's see. I have spoken about this with Team Hughes from Australia.
Yeah.
And he says that this arbitrary cutoff of 10%, 12%, 13%, if everything else looks good, you might try. I mean,
Absolutely.
he was not against trying. So, I mean, that
It's very interesting and heartening to know, I guess.
Yes. That's what he said. But then, yeah, let's see.
So, sorry, Gargi, I know time is really short, but this is for Dr. Rajan as well as Nirmalya. So I was reading the JAMA guidelines for adult CML, and they have recommended trying TFR after 5 years of deep molecular remission, whereas the pediatric guidelines say 2 years. So can you, in our everyday practice, we really try to now think when we should try TFR. So should it be after 2 years or should it be after 5 years of DMR?
So, as you correctly pointed out, as of now, we are still following the 5 years even in adults, but it has come down to 2 and 3 years also. So the newer ones, they have come down to DMR with 3 years. But if you ask me, the study which we are doing, we are still taking as DMR for 5 years. But in pediatric, as you have brought it out, I think it is 2 years. But
Yes, no, not only pediatric. I mean, when we started this study, we took the recommendations from the NCCN guidelines. NCCN guidelines were more liberal. I mean, 3 years of TKI and two
yeah,
years of DMR, whereas the ELN guideline was more conservative. They had 5 years
yes.
actually, and I am not aware of this JAMA guideline, which must have come recently. But then, yeah, so 2 years and 3 years, yeah.
So for our study, we are still following that 5 years for adults, the one which we are planning with the HCC. So to be more
Right.
conservative, yeah. But the thing is that our ballpark figure has never crossed 50%. Your 60% plus is really very encouraging.
Yeah. I mean, we need more long-term follow-up, but then
Yeah,
I
yeah,
think because many of our patients are on long-term TKI. So
mm,
when we say the cutoff of 2 years and 3 years, actually, if you see the mean duration
yeah.
of
Yes, I
DMR
saw.
in our patients was close to 5 years actually. So maybe that's why we are seeing a higher TFR rate, but let's wait for long-term results.
Yeah.
Thank you. And then the other question is on switching TKIs. So the first is maybe Deepak sir can take it up. We have a patient who doesn't achieve an MMR for 18 months or even 2 years, but the cutoff is low only, patient is stable in CHR. We see such patients. So what would you do in such cases? Or, and again, if a patient doesn't achieve a DMR, do you respond or is it okay to keep an MMR as a target?
So that's a very good question, and we do see it every day in clinical practice. So as per the guidelines, one is not supposed to switch if the level is below 0.1%. That is what the guidelines say. So of course, compliance, that is the most important. And then if on a drug, the levels, patient is not going into DMR, one could ideally should be doing imatinib levels, which are not available to us. So in clinical practice, sometimes we increase the dose of imatinib, which somehow the literature hardly talks about. I mean, we do plasma, I mean, the literature says do plasma levels and then increase the dose if the plasma levels are low. But so I don't know what Dr. Kapoor would say to increasing the dose of imatinib in everyday practice.
Yeah, as you have rightly pointed out, no guidelines now say that increase the dose. And now with the generic second generation coming, we also have stopped increasing the dose of imatinib as such. As you said, we have hardly ever done the imatinib levels, and we generally switch over to second generation. But as you had pointed out, the level of molecular response, like the MMR is acceptable to us. We do not shift just because the DMR is not being achieved.
What about if they don't achieve MMR? If
Then,
for a
So,
long time,
Gargi, there
then
is recent data from MD Anderson Cantargian group,
yeah.
which shows that 1% is also okay.
Oh, for how long though?
So I mean, I don't know I mean,
we are
how far the goalpost will shift, but then his data suggests. I mean, MD Anderson. I mean, which is something out of the world actually. I mean, they don't have data that corroborates with the rest of the world, but then they say 1% response is compatible with overall survival as good as patients who had better response. So
Absolutely. I think for adult and elderly, I'm absolutely happy with 1%. If they have a CHR, we have many patients going on like that, but I'm not very sure in pediatrics we can uh, take that kind of a risk with 1% and not doing anything, because we start preparing for the other modalities of treatment when it is increasing.
Um, the other question, I'll sort of summarize 2, 3 questions on intolerance to TKI. You'll have a patient, we'll start on one TKI, you'll switch, you'll keep switching, and they'll have either cytopenias, hyperbilirubinemia. One of them mentioned they had some skin rash, and then the non-tolerance of dasatinib, second generation also. So how do you manage these cases? At what point in these cases do you say, okay, it's enough and we probably need to go for a transplant? So, like anyone, Dr. Kapoor?
Yeah.
Yeah, in our pediatric practice, we hardly ever see intolerance to imatinib. We do see some muscular pains in the beginning, but they tend to get over. So Dr. Kapoor did mention muscular pains and preferring dasatinib for a football player, which I think is from a journal, and that seems reasonable. But in our practice, we generally see that they get over after a few weeks to months. Vomiting is something which sometimes even patients who have been on chronic use do complain, and many of us are not aware, but it's a moderate emetogenic drug. So MSET ondansetron can be given half an hour to 1 hour prior to taking imatinib.
Okay.
So, and cytopenias are very well known in the first 3 months, and the international guidelines to which Nirmalya is a co-author is clearly written that even if you have cytopenias in the first 3 months, you can try not to reduce the dose and continue the drug as it is. Thanks.
And use GCSF or something like that. That was also written.
No GCSF, without stopping the TKI. So, you can't do both the things together. So, by cytopenia means you actually can tolerate a lower level of ANC and platelet. So, in our practice, we tolerate it till 0.5 and 50 before we stop the TKI. Especially in the early months of the treatment. But then, of course, if it comes to GCSF or platelet transfusions, you would stop the TKI. That's what.
So we see a few in our adolescent cases. So, Sir Kapoor sir, when would you consider transplanting them? I don't know if it's the same case in young adults and adults. Intolerant.
So, as I said, CML, though it's a very amenable to transplant, but we hardly do any transplant nowadays because of an excellent response to TKIs and the availability of second generation and now the third generation. So, the transplants have drastically gone down to CML. So, we restrict the transplants only to the CMLs who actually, with the earlier definitions, maybe accelerated phase was not responding, or the blast crisis. So, the blast crisis definitely we want to do, and the moment they achieve a response and go for the transplant upfront. But CML, CPs, it's very difficult to do transplant, even if they have not achieved the DMR. Though it looks very exciting that we should do a transplant for a cure, but transplant has got its own set of complications, and doing a pediatric transplant as it is fraught with a lot of complications. And as has been pointed out, we have been using imatinib, and we do not change very fast from imatinib to second generation in pediatric population, because we have seen the response rate may be delayed. So they may not achieve a very early molecular response. Like in adults, we generally change if in 3 months the BCR ABL is more than 10%. We start thinking about doing second generation. But in pediatric population, we generally wait for a longer time, because we have seen that they do achieve a response a bit later than what the adults do.
And what about this thing of switching to third line if they are not tolerating or a second generation TKI?
So I have a very limited personal experience. So one is that we have used ponatinib because we wanted to do a transplant. As a bridge to transplant, we have used ponatinib. And the second is asciminib. As I said, if you ask me personally, in India, asciminib would be useful only if we use it for T315I. Now, in T315I, it is 200 milligram BD, which is definitely, something which we have never used as of now. We are used in adults as a compassionate access, but not in a pediatric population. But yes, we do have options. But third line, when they go, we generally want to take them up for transplant. As a bridge to transplant, we can use third generation, because I don't think so. I'll take opinion of the others who might have treated with third generation, but we have not been able to continue for a long time any of the third generation TKI.
Deepak sir, that question, if you want to answer, and one more on whether to start the second generation TKI with patients with ACAs upfront.
So I have no experience with third generation. And what is the second question? Sorry.
Whether to start second generation TKIs in patients with additional cytogenetic abnormalities.
So the international guidelines clearly say that additional cytogenetic abnormalities have not been shown to worsen the outcome in pediatric CML. So the answer is imatinib should be good enough. The other thing I think we can quickly discuss is whether anybody has used growth hormones in CML patients on imatinib, because we have given it only to about I think it's about 6 patients, and we have seen some transient improvement in the height. It of course has to be given with endocrinology consultation after they do the growth hormone test. And now with the with TFR coming in so actively, one will wonder whether one should focus on giving growth hormone or trying to quickly achieve a DMR for 2 years and then trying TFR. So Nirmala, any comments on this?
So we have published our growth hormone experience in the previous paper in BJH 2022, where we have, I think now, I don't remember the number. So I think 3 patients of ours got growth hormone. I mean, after proven growth hormone deficiency by proper endocrine workup, and all of them benefited actually. So there was a median, I think, 8 to 10 centimeter gain in height, which is a lot for patients who were. So the main problem that we see with growth hormone is that the time when we actually say that this is not improving and the catch up is not happening, we send them to the endocrinologist. By then, these growth plates are already fused. So growth hormone doesn't work. But then there were previous concerns about growth hormone in leukemia. But then in our experience, safe enough. We can go ahead if they're in remission.
Okay.
And what was your other question, sir? I didn't get that.
No, I think this was it.
Okay.
Okay. So, Vinay sir, would you like to wrap up now, or?
Yeah, I think it was a very good discussion, but we have crossed a lot of time. So, one or two concluding sentences from Deepak sir regarding pediatric CML, just like a blanket thing.
So, I think to some extent it continues to be a challenge for pediatric oncologists because we are so overwhelmed with other diseases that these pediatric CMLs come off and on in between, except for the extremely busy centers. And, as pediatric oncologists, most of us are doing benign, malignant, solids, transplant, everything together. And then in between, you get one off and one CML. So, it's a little difficult to keep abreast with whatever is happening. But at the end of the day, imatinib still continues to be the gold standard. A lot of new drugs are coming up. If you attend adult lectures on CML, it's so depressing because you think that so much is happening. But thanks to international guidelines on pediatrics, they make things very simple, and one has to just keep oneself abreast to what is happening. And this TFR is extremely exciting now. Earlier, we used to tell Zindagi Matlab we'll have to take the drug forever, and now this TFR is extremely exciting. We should ensure compliance to all our patients and try to target TFR soon after 2 years of DMR is achieved. Yeah, thanks.
Please join our TFR study.
Yeah. Okay, that is a very nice concluding thing. Okay, so we had a very nice educative session. So with this, I think we will close the session. Thanks to all the experts and thanks to Dr. Gargi, did a wonderful talk and also moderating the session. So thanks a lot for each one of you and also the participants, students who have joined. Thanks a lot. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you,
Good night,
Vinay. Thank you,
everyone. Bye.
Shruti. Thank you, Vinay. Thank you, Shruti, for taking it forward. Thank you, everyone.
Good night, everyone.
Thank you.
Bye.
Thanks a lot.